we're back for another edition of Doc Talk. We have two very special guests in studio today. One of them in person and one of them has taken the time to video in. So thank you so much, Drs. Ulmer and Dr. Petereit.
Just want to thank you, Leslie, and your group for hosting Dr. Ulmer and myself. We're really excited to be here, and know we only have about 20 minutes. We could give you 2 hours worth of material, but thank you again for inviting us.
Absolutely. And before we dive into it, let's start with you, Dr. Ulmer. Could you tell the listeners and tell me a little bit about yourself, the doctor and the person?
So my name is Dr. Keely Ulmer. I am originally from the Pine Ridge Indian Reservation between Interior and Wombly. I grew up there my entire life. I went to college at Black Hills State University and then on to medical school at University of South Dakota. I then matched into OBGYN residency at the University of Iowa, which is where I still am. Through that journey, I ended up going into gynecologic oncology and am currently planning / the plan is made that I will be returning and starting work at Monument Health in Rapid City in September of 2025 as a gynecologic oncologist. So looking forward to moving back home with my husband and 4 kids and serving the American Indian population, which has been really my passion since going into medicine and medical school, which really seems like a lifetime ago.
Well, and I know that Monument and our community will be greatly looking forward to having you join us and work there. So we're excited to see how that pans out. Dr. Petereit, tell us a little bit about yourself.
So I'm a native of South Dakota. I did my training at University of South Dakota for medical school, was at University of Wisconsin for 10 years, was on staff half of that time at the University of Wisconsin, but decided back in 1999 to relocate my practice here. Part of the reason was Black Hills are obviously gorgeous. I spent a lot of time out here growing up, and also was hoping I might be able to do something that may have a positive impact with the American Indian population. So all this has kind of been almost disbelief what's happened over the last 25 years with walking forward, the programs we've started. And I'm technically a radiation oncologist, but my specialty is in brachytherapy, or where we put radioactive sources in various tumors. On the surface, it may seem like there's no connection or correlation between cancer disparities in what I do in my practice, but there actually is, and we'll get into that a little bit. So I'm also married, have 4 kids. They're much older, and it's great to be here today.
One of the core themes we're tackling today, the importance of cervical screening and the treatment that follows. Could we touch on that? I know it's a very broad subject, but why is this such an important thing to keep in the public mind?
So just a few comments, and I want to turn it over to Dr. Ulmer because that's really her wheelhouse, so to speak. But I, as a treating cancer physician, have no impact till someone presents to my clinic for the screen detectable cancers, lung, breast, colorectal, prostate, and cervix. And so what we've been doing in the tribal communities is really a strong navigation program to promote screening. Cervical cancer, like other cancers, is, if detected early, is very treatable and highly curable. And then maybe Dr. Ulmer can get into more of the screening issues, who's screen eligible, and what are ways that we screen women, both native and non-native.
Yeah, so talking about cervical cancer in general, I would echo what Dr. Petereit said. And as a gynecologist, gyn-onc now, I think I've really throughout my training and practice is I've had some experience on both the more primary screening side as a general OBGYN and now as a gyn-onc. I really can't change the past when people present with an invasive cervical cancer, but echoing exactly what he said, screening should remain in the forefront of our conversations because this is a screenable, detectable, treatable, curable disease if caught in the early stages. However, it gets much more complicated when it's caught in the later stages. So cervical cancer screening just in general is pretty complicated. It's been complicated with the screening guidelines throughout, probably the last 20 years. There's been a lot of changes in guidelines. When do we screen? Who do we screen? How often do they get screened? For example, even in my lifetime, when I was an adolescent, the recommendations were that you would screen, as soon as you were sexually active. However, that really kind of is hard to do. What it ended up leading to is a lot of unnecessary procedures on young people who are more likely to clear the virus that is really overwhelmingly responsible for cervical cancer, and that's called the human papillomavirus, or HPV virus. Then, through that, we found that screening people when they were very young, they were much more likely to clear the virus on their own, led to a lot of unnecessary procedures, which led to a change in guidelines, such as currently right now, we don't screen anybody until they turn 21. So that's the current recommendation, is that you start screening at 21. A little less frequently. You don't really test for the HPV virus between 21 and 30, again, because as a younger person, you're much more likely to clear the virus because you have a robust immune system. Then the guidelines slightly change when you turn 30, and the typical screening period is 30 to 65. There's a few rules in there, and really the screening, how we've developed it now, is really all about risk stratification. So, how abnormal are the cells? Is there HPV related? If it's HPV that's related, is it one of the high risk strains? There's a lot of strains of human papillomavirus, from, a common wart that you get on your finger to the kind that wreak havoc on a cervix and can cause invasive cervical cancer. So it's really all about risk-based assessments. So it's a very complicated algorithm, even for somebody who's in that in that space every single day. It's so complicated, actually, that the society that kind of guides the guidelines on cervical cancer screening, the ASCCP, has a mobile app. So there's an app that I rely on. I would say anybody who does cervical cancer screening relies on, where you input some of the data points that you have, and it really helps you guide your recommendations for each specific patient based on their risk factors. So, I guess I'll just keep talking. I could talk about this for hours. Some of the issues and hesitations with cervical cancer screening it's just it's complicated, it depends on the age. It depends on, between 20 and 30, you shouldn't be testing HPV unless it's grossly abnormal. There's multiple different factors, but also one of the issues and hesitations in the community is just, number one, the population. So you are asking normally healthy women or people with cervix to screen, and they, it's just not really in. I even know when I was younger, it really wasn't in my day-to-day thought process that I needed to be going in and having a speculum exam, which is not the most comfortable thing. So you're asking people to do something when they're otherwise healthy, probably not getting a lot of medical care. I mean, I know that I could still be better about seeing somebody and having a primary care provider because I'm young and I'm healthy and I don't have really anything wrong with me. So a lot of issues and hesitations with it is like people, aren't seeing providers regularly, or when they do see their providers, maybe they're not super up to date on the screening guidelines and they're not getting screened. And then also it's kind of invasive. Our current way of screening for cervical cancer involves an invasive exam, an invasive internal exam with a speculum. It's not comfortable. It's not something that's fun. And so it's pretty easy to avoid that. I think that one of the populations that's most likely to get screened, that I've seen both as an OBGYN and then subsequently as an oncologist, is that women who are having children, or people with cervixes are having children, and they get cervical cancer screening during that pregnancy, but then let's say they're age 29 and they have their last child, and then they don't see a provider for 20 years and don't get a cervical cancer screen for 20 years, and then they show up with a advanced cervical cancer. So I think really a lot of the issues are, it's not comfortable, it's not fun. The recommendations are a little bit complicated, and we're asking a population to screen that usually is overall healthy. So that's some of the problems and the issues with cervical cancer screening. And I guess I'll just keep talking. Part of the problem with the Native American community or American Indian community also is, the lack of healthcare access. There's not a lot of OBGYN coverage, especially in Western South Dakota among the American Indian population. And then there's a mistrust of the medical system, which doesn't help either.
Absolutely. And I think this is an excellent time to slightly pivot into your study and the recent articles that have been published, which, if I'm correct, dive into population-specific data and researching that and how it is impacting the American Indian women in the Northern Plains. Would you, or folks with cervixes, would you like to dive into that, doctors?
Yeah, so Dr. Ulmer, once you talk about the first paper that's going to be published in a little bit, the whole Northern Plains one, and it might be helpful for the audiences to mention the vaccines for a moment,
Sure.
because that's a critical part of the story. But maybe I'm always pushing Keely on this because, one, I want people to know who she is, and two, she's an absolute expert. But maybe talk for her a little bit about vaccines and then talk about your Northern Plains paper. Then we can get into the second paper that was just recently published.
So HPV vaccination, I'm actually working on another a study with HPV vaccination, but HPV vaccination, as I had mentioned briefly, when we're talking about cervical cancer screening, one of the things that comes into play is that HPV, or human papillomavirus. We know that causes HPV is directly responsible for over 90% of cervical cancers. And not only cervical cancers, actually, there's 8 known HPV-driven cancers. So cancers of the anal cancers, cervical cancers, head and neck, and throat cancers as well.
Oh, wow.
So those are all primarily HPV driven. And so there was a lot of research done into an HPV vaccination. And I believe it was in like the 1980s, they found that HPV was related to these cancer types. And then in the early 2000s, there was the development of an HPV vaccine. Originally, it only covered 4 of the high-risk HPV types, but has subsequently been expanded to 9. It's a 9-valent vaccine that covers 7 high-risk types and 2 low-risk types, the types that are more common for warts, just like the benign warts, but still can be a major problem for people. And so that is currently the only vaccine, the 9-valent vaccine called Gardasil, that is available in the United States. But the recommendations is routine HPV vaccination between the ages of 11 and 12. So actually targeting adolescents. And the reason for that is, number one, that's when these vaccines have been shown to be the most effective. And then the second reason for that is it's actually bundled with other types of vaccinations, like your tetanus, diphtheria, and acellular pertussis, as well as your meningococcal vaccines. So by bundling HPV with those vaccines at a more effective time frame in younger life has led to the recommendation for routine vaccination of all male and female adolescents between the ages of 11 and 12, but actually several studies have shown that if you move that age up to the age 9, they're more likely to complete the series. Depending on their age, they either get 2 or 3 vaccinations, and it is very, very effective at preventing HPV-related sequelae. So even precancers, cancerous lesions, and the goal really is to have widespread vaccination to decrease the rate of transmission of HPV, because it's not just going back to kind of the some of the more historical things is when the vaccine came out, it was primarily female centered. It was only approved for females, which led to, there was a lot of young girls that were getting the vaccination, but none of the young males. But this is HPV affects both sexes, and it's transmitted that way as well. And so unfortunately, with it being female centered at the start, and differing guidelines, it led to a lot of people not being vaccinated at all, which decreased the efficacy of a very highly efficacious vaccination program. So in the last 10 plus years, there's been a huge push to vaccinate both equally. Unfortunately, that's still lagged behind other vaccinations such as the meningococcal vaccine. So very effective, very useful, but you have to also have people buy in. And there's a lot of misconception around who gets the vaccine, what it means, and some of the hesitations as far as that, both providers and for patients and parents when HPV vaccination is recommended for their young adolescents.
I was going to ask, I've seen an increase in advertising for the HPV vaccine, and it's really focused on, getting your tween or pre-tween child vaccinated. Have you seen, anecdotally, a less reluctance about that because of finally clearing up those misconceptions? Because when I was younger, anecdotally again, getting that HPV vaccine to some may have seemed suggestive, and that's not what it's about at all.
Absolutely. You hit the nail 100% on the head there. It was subjective of young teens and tweens being sexually active. And, that carries a big stigma, but it also is, not there's also some reality there that I think is sometimes hard to grapple with. So both anecdotally and objectively, there has been improvement in the uptake of vaccinations. So another study that I'm currently working on looks at HPV vaccination rates among a more disadvantaged population of all races, and also compares that to national rates. And national rates have improved. The healthy people goal of 2030, so the CDC's goal by 2030 is that 80% of the adolescents aged between 9 and 18, hopefully 9 and 12, would be vaccinated against HPV. We've seen slow but steady gains. There was a pandemic dip, of course, but I think that successful campaigns really in the public purview as well as for providers, because what we found is one of the major drivers for adolescents getting HPV vaccination is actually provider suggestion and provider knowledge. So with both provider education as well as public information around the HPV vaccine, those rates have improved, but are still, unfortunately, well below the 2030 goal. Most recently, nationally, in a survey of teens aged 13 to 17, which is technically called the catch-up period, where they need 3 vaccinations instead of 2. The rates were around 70% for both male and females, but among some of the more disadvantaged groups, that's more like 60 or mid 50s. And actually, interestingly, some of the groups that are least likely to get HPV vaccinated are non-Hispanic whites. So although there's a lot of data surrounding disparity of HPV-related cancers, so people who are non-white race tend to have worse incidence and mortality from HPV-dependent cancers. In the last decade, actually, non-Hispanic whites are the least likely to get vaccinated in several studies.
Wow.
Which I think probably goes to show probably more successful marketing, provider recommendations, and increased initiatives in those populations to increase HPV vaccination.
That makes sense. And we've touched on the evolution of the HPV vaccination. Let's also touch on some cervical cancer treatments, surgery versus chemo, and some new studies that have developed. So I might hand this over to Dr. Petereit.
Sure, and I know what this is eventually leading up to is, and how to get to the point on this, but unfortunately, the American Indian women in South Dakota have the highest cervical incidence of cervical cancer in the U.S., and the mortality or death rate is twice that of other populations. And so that's why Dr. Ulmer has one study for the Northern Plains American Indians, looking at the American Indian population versus the non-American Indian. And then we did a similar study with all the patients we see at Monument at the Cancer Center. And some of the overarching themes are, higher incidence of cervical cancer and higher death rates. And as this relates to the HPV vaccine, because we did another study, about 10 years ago, because we want to get into, how can we overcome some of these disparities. But there's a lot of HPV strains that the American Indian population have that are not, in which the vaccine doesn't work. So that's cool. Another, and Keely might want to touch on that a little bit, and then we can get into treatment. And then the big question is, okay, what are we going to do about this? Because we have a really robust plan to try to lower cancer death rates for these women. I mean, all the women in the state, but in particular the American Indian women.
Where the disparity lies. Yep. That makes sense.
Yep.
Dr. Ulmer?
So, like Dr. Peter was saying, I did do a study in the Northern Plains among American Indian women, and there's been studies that have been done before by other South Dakota gynecologic oncologists, and he is 100% correct that HPV vaccination is slowly and steadily improving, but unfortunately, a lot of American Indian women have HPV strains that aren't covered by those nine types that I was talking about previously. And so I think that between that and then lower use of cervical cancer screening in general can lead to these increased incidence and mortality, and especially among women of the Northern Plains, that disparity has persisted for a very long time. So we're talking about increased incidence, up to close to 4 times that of non-Hispanic whites or other populations in our area. And then the mortality is much higher. Now, as a gynecologic oncologist, I think that, likely one of the problems with that is access to care is always a problem. Under the understanding the recommendations. And then also, I think, one of the things that we found in our study that Dr. Petereit was talking about. So my study really kind of confirmed that I did at the University of Iowa, really just confirmed like cervical cancer is a problem. It's still a problem. It's really not getting better among the American Indian population in the Northern Plains. And it's getting better for the other populations in the Northern Plains. So like we're still missing something here. Like HPV vaccinations getting a little bit better, but cervical cancer incidence and mortality is not improving. And so there's definitely a problem there. And then, the study that I did with Dr. Petereit really showed, it's a multitude of factors, as everything is. It's all the problems that I have lived in my life living on the reservation, the access to care, having lack of follow-up of abnormal results, not getting, guideline concordant care, not getting guideline concordant screening. And then another thing that we found in our study with Dr. Petereit, and myself and Dr. Harper from Michigan, was that, also there's some delays in care when people present with symptoms. So they present with symptoms of cervical cancer, such as abnormal uterine bleeding, having difficulty urinary symptoms, abdominal pain, and they present with 2 or more symptoms, and they're referred out instead of doing like a biopsy of something that's grossly abnormal on a pelvic exam, and that delays their them getting the care that they need, which is specialist care. So when we kind of depart from normal cervical cancer screening, follow-up, low-risk interventions for precancers, and we get into the invasive cancers, especially if they're locally spread, they need the care of a specialist, such as gynecologic oncology and radiation oncology. Really, we kind of go hand in hand. Gynonc and radiation oncology go hand in hand when it comes to invasive cervical cancer, because these people are stratified based on multiple factors to either surgery, chemo, radiation, and some combination of that.
Understood. So that particular population would encounter what we civilians would call red tape, right? You have these abnormal symptoms, their care provider would refer them, and that would delay the process in receiving the adequate treatment, therefore increasing symptoms and potentially mortality rate, and that's a huge disparity.
So early stage disease, this is kind of general, and we prefer patients present with early stage disease. They need to have a radical hysterectomy. We'll let Dr. Ulmer talk about that a little bit. In my world, all the patients that I see tend to be very advanced. So once they're above a certain stage in tumor size, those women are still curable, but it requires a combination of daily radiation with chemotherapy once a week and brachytherapy. So brachytherapy for this population, even if they're stage 3 disease, the cure rates can be as high as 70 to 80% with proficient brachytherapy. So that's my other passion. I've worked on this at a national level. And this is what we talked about this in the prostate cancer a year ago. But for women with cervical cancer, if they're not a candidate for surgery because they're more advanced, brachytherapy is going to be, I would say, in a sense, kind of like the surgical approach, is that they have to have this or they won't be cured. And there's been a lot of advances in how we do it. It's fairly complicated, but even for a stage 3 patient, their cure rates are quite high.
And for transparency's sake, brachytherapy is?
So internal radiation, I've tried to sanitize this a little bit. So when women, so the general idea is when let's just say we have a patient with more advanced stage disease, they need daily radiation Monday through Friday for about 5 weeks, chemotherapy once a week to shrink the tumor down. And then we do a procedure where we put these devices that, while they're asleep, they're called the tandem and ovoids. You can Google on it, but this has been around for 100 years, but it's much more sophisticated how we do it now. But we put these instruments inside of the vagina, cervix, uterus, put catheters up into the cervix. We do a CT scan, MRI. This is a very complicated process, but eventually a little radioactive pellet goes inside of the patient and gives a high dose of radiation to those areas. We end up treating them 4 times. Sometimes we'll do 2 treatments in 24 hours and they're in the hospital overnight with an epidural and for pain control. Sometimes we can do it as an outpatient basis while they're asleep for 4 different times. But even though the technology is much more sophisticated with using MRIs for tumor delineation, again, on a national level, I worked on this to make certain that not only our population, but all populations, especially rural and disparate, have access to proficient brachytherapists. So we actually started a program nationally to train people, because residency programs aren't training a number of proficient brachytherapists. It's called 310. The goal is to train 30 competent brachytherapy teams per year over the next 10 years. So ideally, all these patients would be seen by Dr. Ulmer. She would see them regardless. They could have surgery, they're cured, and they don't need to see me. So part of my goal is to put myself out of business, so we don't have to put women through all this, but it's still very effective if they need to have this kind of treatment. And then, Keely, maybe you can mention a little bit about surgery, because this isn't a surgery that's done by OBGYN docs. It requires a highly trained professional like Dr. Ulmer.
Correct. So, like Dr. Petereit was saying, it's really highly dependent on what stage. So, the thing with cervical cancer is the best time to treat cervical cancer is when it's not a cancer, when it's a precancer. It's highly treatable with very minimally invasive procedures, which is just essentially like a cervical excision. So that is where the screening part comes into place, because if you catch it even at some of those early stages, you don't even need a radical surgery. However, when it's morphed into invasive cervical cancer, it really depends on, there's a lot of factors. Is it microscopic? Sometimes you just need either that cervical excision if you desire fertility and you want to spare your fertility. And that's a whole nother discussion, which is beyond this purview. But if it's a visible lesion, but it hasn't. So how cervical cancer spreads is it starts in the cervix, and then it essentially just kind of spreads locally. So it spreads through the cervix up into the uterus and out into what we call the perimetria, which is essentially just the tissue that's by the uterus that contains the blood vessels. It contains specifically the ureters. So, common speak, just like the tubes that drain the kidney to the bladder. And so once it spreads out into that perimetrial tissue, you're at a more advanced stage. Surgery really only comes into play when it's still localized in the cervix. And the reason for that is that when you do this surgery, it's called a radical hysterectomy. And a radical hysterectomy is essentially just that you're taking a lot more tissue. So you're taking that perimetria. So all that tissue that's kind of around the uterus, where the ureter lives, where there's a lot of blood vessels, the blood vessels that like become your major blood vessels, it's an open procedure, and it takes a lot more technical skill because you're trying to get all that tissue. And when you're thinking about who needs the radical hysterectomy and who doesn't, your goal is that when you take that out, there's no cancer at the edges of what you cut out. Because let's say if you cut through cancer and one of those margins is positive, you really didn't do that patient a favor. And you also sample the lymph nodes, because not only does cervical cancer spread just kind of locally, it also spreads to the lymph nodes. So you do this radical hysterectomy and pelvic lymphadenectomy to see if there's any microscopic spread in the lymph nodes. And then to make sure, and pathology will go through it very, very carefully to make sure that there's no cancer at the edge of what you resected, because if you did that, then they unfortunately, even after surgery, still need some sort of radiation. Now, that's why you stratify your patients very carefully, because the worst thing you don't want to do is, and sometimes you don't get this right, it's an art of medicine, but what you don't want to do is you don't want to do this huge surgery and then have a positive margin and then they still need radiation, when radiation is actually very effective. So really, kind of depending on the stage, that's one of the surgeries you can do, and that's actually it's curative. So that's the whole goal, as long as you get negative margins. And then if it's more advanced stage, like Dr. Petereit said, then you're looking more at radiation therapy. Unfortunately, that means it's more locally advanced. It usually involves bladder, ureter, sometimes bowel, and people can have a lot of sacrilege from that, even such as fistulas and stuff. So again, like you just hammer on prevention. If you can just prevent or find it a little bit earlier, it just really leads to better outcomes in both morbidity and mortality.
And I hope one day, respectfully, we could put you out of business, Dr. Petereit.
Absolutely. I'm going to be retired in 3 years anyway, so we better hurry up.
And I would love to speak on I would love for both of you to speak on your efforts to put you out of business, which of course is your study and recent grant submissions, and what is happening moving forward.
Yeah, so let me just kick this off, and then Keely's super articulate, and Leslie, you're doing a good job getting a word in, because she and I can talk for hours.
I love it.
So this is a new screening pathway for screening Native American women at risk. The conventional screening is with speculum-based screening, which a lot of women, as a male, I can only imagine it's not a comfortable thing for women to go through. But we're going to be looking at a new solution doing primary HPV screening with self-collection. So what does that look like? So the core of Walking Forward, so I'm the principal investigator of Walking Forward. We've been funded by the National Cancer Institute for now 22 years. We've had almost $20 million in funding. We have 9 people that work for us. Keely, Dr. Ulmer, will be the next PI when she comes out here. I'll still help her, but she's, what a perfect person to take over, Lakota female GYN oncologist. So you've heard the whole preamble, why this is important. And so we'll get into, so with our navigators, so we've been doing this for years with breast cancer, lung cancer. We have another lung cancer screening project going on right now using LDCTs. But rather than doing speculum-based screening, this will be a self-collection, which will be less invasive. The women do this themselves. We will be, and this gets a little bit complicated, but at the core of this is we're going to be doing like any other NIH grant. So why this whole preamble is so important is if we put in this grant and we didn't have this background information, if we didn't demonstrate to the reviewers at the National Cancer Institute that, 1, we know what we're doing, 2, we've done this for 20 years, and 3, there's a need, it would never be funded. So these articles that we'd recently published, that's the currency that you have to speak when you're competing against the Harvards and everybody else in the world. So as part of this, there's 3 aims, but a big part of this is to engage community stakeholders to develop educational sessions explaining the new cervical cancer screening pathway. The second aim is to demonstrate a newly co-developed curricula with medical professionals. And then our community navigators, this will be done in Rapid City, Pine Ridge, and Cheyenne River, because we have American Indian staff that live, and most of our staff are American Indian. But our goal is to provide these educational events, and then if women are screen eligible, we want to screen 300 women through a HPV self-assessment, and I want Keely to take over in a little bit, rather than conventional speculum-based screening. And then if they do have a high-risk HPV, then they would go on to the next, a little bit more involved screening with the speculum, but it's really a new screening pathway. And so we'll have out in the community female navigators that are Lakota doing educational sessions. The goal is to navigate 300 women through this new screening pathway. But we're also interested in sustainability. We want this to become a standard approach, and there's a recent guideline that came out from the U.S. Preventative Task Force that this is probably going to be an appropriate pathway for women to self-screen themselves. But Keely, I'll kick it off to you next.
Well, and before, if you don't mind, Dr. Ulmer, I would like to ask for anyone listening who may not have a medical background, and this might just sum up a lot of your research, what is the benefit of self-screening? Which barriers are we jumping over? How are we making that more How are you making that more accessible by promoting a level of agency in that first step of the screening pathway?
Well, I think we can refer to ourselves as the collective we, because we're all in this together, right?
Right.
Really, I think the major boundary that you are getting past is the boundary of, it's not that people don't. I hate to I think one of the common discourses is that people don't get it, and that's not true. Like they either just don't know about it or they just put it off. Like anecdotally, that's what I've seen. It's not that people don't get it. It's just that they don't. They're either afraid because it's been so long, or they don't know what it involves, and they've only heard horror stories about like what a speculum exam entails, because it is uncomfortable. Like it is kind of invasive. Like it's also embarrassing, and then it's also just it's easy to put off. It's easy to be something like, oh, I'll do that next year, and then pretty soon next year is next year, and next year is the next year, and then it's been 10 years. And I think what the HPV self swab is eliminating is number one, issues with access to care and care providers, and also people who maybe don't have that primary care provider, don't have access to that. It definitely eliminates the fear of going in and having a speculum exam. I mean, I do it as a living. I do it every single day, and I don't like to do it. So to ask, somebody who to ask people to do that is sometimes kind of hard, or they hesitate, or they just put it off. So I think you're overcoming access to care, and I think you're overcoming some of the fear. It's a simple self swab. It's really the way of the future. Again, kind of going back to HPV, we know that it causes the vast majority of cervical cancers, and so these self screenings where you can be in the privacy of your home, and it's about as simple as a lot of other things we do as women, trying to really kind of keep this PG. It's an easy thing to do by yourself that's not as invasive, and it has been shown to be very highly effective. And I think it overcomes some of those barriers of lack of access to care and fear, and also just inconvenience, to be honest.
So as part of this study, it'll only be females that are doing the workshops. I've been told not to come, which is fine. I get it as a male. So we've set this up, and so Dr. Ulmer's program, University of Iowa. So these women will do the self-swab assessment. Our staff will collect them. They'll mail them. This is all going to be under an IRB-approved protocol that includes Iowa, Michigan, Rapid City, OST, IRB. So because we've done this a long time, but it's very important that we go through all these appropriate protocols. But then the swab will be mailed to the lab at University of Iowa, where they'll do the HPV testing. And then we estimate about maybe 10-15% of the women will have higher risk strains. Then they go down a separate pathway to actually go through the speculum exam. Dr. Ulmer can talk a little bit more about that. But it really could be a game changer. And then I've heard from my patients, and I've heard from my staff, well, gee, we know the provider in Pine Ridge. It's embarrassing. We don't want to go there. This is a major way to kind of mitigate that barrier. And it is probably going to be approved in the next couple of years. So we're really well ahead of the game on this. And now you think about what the strength of this proposal. So the person that's going to be helping these women will be Dr. Ulmer, who's a female Lakota GYN oncologist who's going to be working out of Owate as well. So it couldn't be a more perfect story for the NIH with these reviewers to look at this and say, yes, this is something that we want to fund.
Yeah, and I think, building on that is that I think another benefit of this is that, the majority of patients aren't going to have a high-risk HPV screening or HPV subtype. So you're talking like 90% of the people who are doing this HPV swab are just going to get to do this HPV swab and move on, or maybe do it, maybe in a little bit shorter time frame, but get to move on. And what it's really catching is, I think you're going to catch, not only think, like I feel in my heart, like I know that it's going to catch the people who maybe aren't screening because they don't want to go in, they don't want a speculum exam, have a high risk HPV type, and we can maybe actually catch those people earlier. And yes, they still do have to go in then, but it makes it so much, I think I've seen a lot of women who maybe have a lower risk type or maybe get screened once and they have a low grade abnormality and it's just like, oh, whatever. They let it go for 10 years and eventually it like morphs into an invasive cervical cancer. At least this is risk stratifying people to like, if you're low risk, it still doesn't mean that you have to go in for a speculum exam. But if you're high risk, it puts you just like, it at least raises the red flag of like, hey, you've got something going on that can eventually, that will, not can, it will eventually become something really bad that this population, our population, my population struggles with, and has terrible incidence of mortality from. Like, let's use our patient navigators. Let's get you into the follow-up. Let's nip this in the bud before it's like something that's really big and bad. And that's what I really think that this is going to do. And again, it's only like 10-ish%. Actually, the FDA has approved the HPV self-swab. Right now, the USPSTF is just really, US Preventative Task Force is really just kind of trying to finalize the guidelines, because this is a little bit of a switch from the cytology or like the cervical swab based screening where you use the speculum exam and you like brush the cervix. That was always coupled with HPV. So this technology is there, but this is like a departure from that where it's just the HPV because we know that drives cervical cancer. So it's FDA approved. Now we're just really figuring out what exactly are the guidelines going to be. Right. But it really is the way of the future. And I think our grant really is, thankfully, a little bit ahead of its time. I think that it is being submitted in a very good time frame, and I think it's going to make a very, very positive difference in the American Indian communities for just so many reasons.
From what I've heard, I couldn't agree more, and I'm really interested in following your research and this grant. It also seems like a huge part of both of your missions is to continue this outreach and education, not just to populations with which there are these disparities that you've already covered, but providers as well.
Yeah, so that'll be a big part of what we do, because we're doing this currently with the lung cancer screening project. I mean, one of my key motivations is, I mentioned before, is, patients with lung cancer, they're coming in with a lot of, the American Indians, metastasis to the liver, bone, brain, they're not curable. There's a screening test, and with a lot of net education to the primary care physicians in the community outreach, it's the same thing for the cervical cancer, right? And referred a lot of brachytherapy patients from a 4-state area because there's not a lot of people that do this. And the women I see coming in, and most are from tribal communities. I mean, it's stage 3, it's stage 4 disease. I mean, it's god awful. Then we have to put them, they still can be cured, but it's like, gosh, we have a screening test. And so that's what I'm really excited about. I mean, this really could be a huge game changer.
Yeah, and there's a lot of literature really about the strength of provider recommendation, and also provider education about not only the screening itself but the follow-up of abnormal results. Like, that's really key. So I mean, I think one of the major challenges is to get people to do it, number one, but to get people to do it, it's both the education of the people themselves, but also their providers. So if they're seeing a provider, like, catch that person, to have that in their mind that, sometimes as an OBGYN, I'm constantly thinking about it. So I'm catching people all the time. Like, one of the first things I think about if they come in for a completely separate complaint is, when was your last pap smear? Because if this is my one chance to like convince you to do it, I'm going to do that today. But I'm an OBGYN, so of course that's what I'm thinking. We need to educate all of the providers who are providing any sort of primary care, preventative medicine, to really, like, this is an alternative. This is something you can do. This is how you educate the patients, to really hit this in a multifaceted approach to increase screening and detection of precancers or even early stage cancers, and really try to chip away at that incidence and mortality that has just not improved over time.
And on top of that, it also seems both of you doctors are really trying to spur more interest in the OBGYN field with medical students, getting more interest and involvement from the future generation of doctors as well.
Well, absolutely. So we had medical students involved in the last project, and it took them a lot of time to pour through probably 2,000 charts, retrieve all the data. We had University of Michigan, their group, analyze it all. But yeah, it's an important part of our mission too, as I noticed for Dr. Ulmer, to get the next generation interested in doing this kind of work.
And on top of that, increased Native representation in medicine, which is extremely important.
Extremely important. I think that, that's one thing that I'm granted the opportunity as a Native American physician, is that, I really kind of came into medicine blind. I was, I have a cousin who is in medicine, but me being from the res, it was like, representation matters. So I had never even viewed myself as capable of being a physician. And I think that that's where that representation matters. I was a little snot-nosed kid from the res, and I really didn't view myself as being able to achieve this. And I think, now I've really taken it upon myself to mentor other Native American Indian students in healthcare, either pre-med and med. And I hope to continue to garner those relationships. I've also been in contact with some students from North Dakota and the coasts who are interested in OBGYN. So I hope that, through that we can increase the American Indians in healthcare. And of course, for me, I'm an OBGYN gynoc in women's healthcare. And I think that by doing that, we can also decrease some of these disparities.
We are so fortunate in the Black Hills in our area and nationwide to have providers that are so passionate about what they do and continue to further research, further their initiatives. So Drs. Ulmer and Petereit, thank you so much for coming in. We are really looking forward to following your research and seeing the impact that you both will definitely have.
Thank you for having us today.
Thank you so much.
Thank you.